Good afternoon, everybody. I'm Deborah DeBruin. I direct the Center for Bioethics here at the University of Minnesota, and I want to welcome everybody to this month's Ethics Grand Rounds. We're really delighted to have Dr. Kamisha Russell with us this month to talk to us about the case for healthcare reparations. Let's begin by talking a little bit about sort of housekeeping concerns for the day. So if you have questions for the speaker, please use the Q&A function that you'll find at the bottom of your screen to type in your question. We'll save all the questions and have a discussion based on the questions at the end of the talk. But you can enter your question at any time, so feel free to do that. If you're having technical difficulties, you can also use the Q&A function, and center staff will be monitoring for those issues, and they will deal with those questions with you privately behind the scenes. Today's event is being recorded, and we want to make sure that everyone knows that after the event is finished within just a few days, the event will be available on our website, as most of our events are in our archive. That archive of events is gotten to be a really rich resource of expertise, really interesting discussions on bioethics issues. They are free to use, and so please feel free to check that out if you're interested in seeing a recording of this event or any of our previous events. After the event, we will be asking you all to complete an evaluation. I want to really stress that we take your input on Ethics Grand Rounds very seriously. And so I encourage you to complete your evaluation and submit it if you can. There are many ways in which you can do this. A link to the evaluation form will pop up in your web browser after the event, so you can complete it right away. We'll send out a post-event email with the link, so if you can't complete it right away but want to do it later, that's fine. It's also linked in in a document in the chat that's available in the chat, or that soon will be available in the chat, called the presentation details document. That contains all of these details that I'm describing now. Next slide, please, Kayleen. So for folks who are seeking credit for attendance at this talk, there are really three kinds of credit I need to discuss with you. The first is what we lovingly at the U of M call IPE credit, or interprofessional education credit. This is credit for University of Minnesota health professions students. And for those of you who fall into that group or those groups, if you'd like to pursue IPE credit for participating in this webinar, please complete the reflection form that you will find linked in that presentation details document. Or if you have questions, you can follow up with the center about how to seek that credit. For those of you who are working professionals in health-related fields who wish to pursue continuing ed credits for attendance at today's event, you can request a certificate of attendance. Again, the form will be linked in that presentation details document that'll be available in the chat. I just want to note that based on the expectations of the accrediting bodies, this is not a Center for Bioethics rule, it's a rule of the accrediting bodies, you'll need to attend 75% of the talk in order to receive a certificate. Finally, biomedical engineering students who are seeking ethics credit for attendance at today's webinar, you can email that email address that is on the slide. You can also find it in the presentation details document in the chat, and you'll be able to log your attendance and then work with your program to get credit. Next slide, please. So I'd like to take a moment to acknowledge and thank our co-sponsors. The Center for Bioethics partners with other university programs on all of the ethics grand rounds programming that we do. And we're really delighted to be able to work this month with the programs that you see here on the slide. So the University of Minnesota program in health disparities research, our medical school, our Center for Anti-Racism Research for Health Equity, our School of Nursing, our School of Public Health, and the Center for Race, Indigeneity, Disability, Gender, and Sexuality Studies. Really a great deal of appreciation to all of our partners. We would really not be able to bring this programming to you without their help. Next slide, please. So without further ado, what I'd like to do is introduce our wonderful speaker to you today. In order to preserve as much time as possible for Dr. Russell to really talk to us about the issues around healthcare reparations today, as usual, I'm just going to give a very quick bio, and you will find the full bio linked in that presentation's detailed document in the chat. So Dr. Kamisha Russell is an associate professor in the Department of Philosophy at the University of Oregon, and she's co-editor of Hypatia, which is a journal of feminist philosophy. She's also the 2021 recipient of the prestigious Baruch Brody Award and lecture in bioethics. I really want to thank her for joining us today and welcome her here, at least virtually, to the University of Minnesota. And at this point, Dr. Russell, I'm going to turn it over to you.
All right, great. Thank you. Let me just get the slide shared here. Can everyone see that, or at least anyone who can communicate with me can see that? Great.
That's perfect.
Okay. Yeah, so hi, everyone, and thank you so much for having me today. I'm really looking forward to our Q&A period, especially. So what I'm presenting to you today is an attempt to bring together my previous work on racism and racial health disparities with insights from Olefumi Taiwo's 2022 book, Reconsidering Reparations. My goal here is really just to present a framework for thinking about racial justice work in healthcare and see if that framework is productive for you, which I hope you'll tell me in the Q&A. You may also be wondering why this is the picture on my tile slide, and all will be revealed in due time. All right, so here's an outline for how I plan to proceed today. We'll do a quick snapshot of racial health disparities. Much more detailed information is widely available, and many of you may be better versed in that literature than I am, so we won't spend too long. Then we'll talk about some of the key concepts underlying Taiwo's constructive view of reparations. That's structure and motion, and then accumulated advantage and disadvantage. Then I'll spend some time talking about the constructive view itself. Next, I'll offer two generally compatible but conceptually distinct ways to apply Taiwo's constructive view to the idea of healthcare reparations. And then I'll close by talking about the health and family justice subsection of the Breathe Act, a legislative intervention proposed by the Movement for Black Lives, which I think offers an example of the constructive reparations in question. So our disparities snapshots, here we have rates of high blood pressure, diabetes, and stroke for African Americans and white people in the US in 2015. This one shows death rates, white and black, also in 2015. And then here we have infant mortality rates for 2017, with other ethnic and racial categories included, not just black and white, but you can see that black non-Hispanic people are at the very high end, and that white non-Hispanic people are at the low end, not the very low end, but right next to Asian non-Hispanic. And then you can see the average in there with the dark blue in the middle. So now we're going to talk about Taiwo. Taiwo, sorry. I'm just going to read you this long quote that describes the understanding of structural inequality that really underlies Taiwo's argument. So, we can look at the politico-economic system of the world as something like a water management system, a web of aqueducts that spans the globe, channeling instead of water, advantages and disadvantages from one place to another. The system describes which way future waters will naturally run and where they will not run without novel intervention. If we try to explain modern finance or philanthropy or pollution or medical care, we end up explaining their motion in the world. The system of the world, then, is not best described by the metaphor of a blueprint or an organizational chart of political powers, but as a set of inertias, gravities, pressures, and bottlenecks that bound and channel the endless flow of the present: material, money, media, violence, advantage, disadvantage. It is their motion in time that makes the system of the world, and we can map the system to the extent that we can predict the direction of the motion. So now the reason for the picture is revealed. I chose the picture because it reflects the complexity of a large water system. But really, Taiwo has spoken of a system of metaphorical aqueducts. And this point is important because, first of all, once constructed, aqueducts work by gravity alone. So there's that inertia and gravity sense. Second, they channel things one way, right? So it's not the dual way system that would be described, that would be in the picture that I showed before. And this means that no matter how much water you might add to a dry part of the system, that water is always still going to flow away from that part, right? Because it's a part that does not hold water long term. So these aspects of the metaphor lead us to another key concept in Taiwo's argument, which is accumulation. That is the way that advantages and disadvantages build up over time. So he writes, since accumulation results from past distributions, this pair of concepts help us understand how past injustice explains present injustice and how present injustice can explain future injustice. And these connections are essential for any successful argument for reparations, right, which always has to connect the past to the present and the present to the future. Taiwo also points out that advantage and disadvantage are often self-reinforcing. So the possession of relative wealth and privilege makes it easier to access greater wealth and privilege, as when, for example, an elite education connects one to high status jobs, or when invested money yields more money without requiring more work. Likewise, an existing lack of access to resources can make it increasingly difficult to gain any further resources, as when a lack of transportation makes it harder to get a good job, or when only predatory loans are available to cover basic expenses and lead to deeper and deeper debt. Further, Taiwo argues that concepts of distribution and accumulation do not apply only to money or material resources, but also to things like knowledge, citizenship, and violence. So the constructive view of reparations is historically informed but forward-looking. It aims to rebuild the world toward justice and do so while justly distributing the benefits and burdens to come with that rebuilding. The ultimate target for constructive reparations projects is self-determination in a just world. So that's the basic definition of the constructive view that Taiwo offers. So some more information about it. It responds to the accumulated advantages and disadvantages that result from global racial empire, but it's not grounded in universal moral commitments of equality or dignity as the explanation for why the well-off should change things for the benefit of the worse off. Instead, it looks at specific global superstructures, institutions, associations, chains of production and norms to ground a distributive justice analysis for specific historical reasons, right? So it's not everyone deserves to live well or to have basic human rights or dignity. It's actually, there's a historical system at play that has resulted in these accumulated advantages and disadvantages. And so there is a responsibility specifically for historical reasons to redistribute resources. So he continues about some of the work needed to employ the constructive view effectively. You must avoid responding to only snapshots of present distribution by continuing to track the ongoing global transfer of resources and opportunities. So again, the motion. Drawing on the social model of disability, it has to be not only about changing or overcoming the limits of people's abilities, but also about removing the limits of social and built environments so that a wider range of people are able to live equitably within them. It requires addressing the patterns of care, concern, and attention that we learn from our mundane interactions. And it does not justify reparations based on a notion of collective responsibility that requires dividing the world into binary groups like white or black, settler or indigenous, colonizer or colonized. This is because that purity and simplicity just doesn't exist in the world, right? So, and this is, I think, really important. I think this is part, that last point is part of the sort of stereotype of reparations. And it's often the sort of where attacks against reparations come from. So basically, because so many of us and so many of our ancestors were not simply perpetrators or victims, and may have both benefited and suffered from global racial empire, Taiwo favors understanding the imperative for reparations through the legal idea of strict liability rather than collective responsibility, which obligates people and corporations to bear the costs of injuries in ways that bypass blame and fault finding entirely. So he says, quote, strict liability questions aren't backward-looking investigations into who did the wrong thing in the past. They are design choices about our present and future. Rather than trying to punish a wrongdoer, we may instead find ourselves trying to build a world that distributes risk in the right way. However we choose to answer the question of how to distribute risk going forward, we should simply notice that it is a different question altogether from one about who to blame for what has already happened, the question lying beneath many conceptions of responsibility. This is still, that was all Taiwo, this is still Taiwo. The racially advantaged, the global north, and institutional repositories of plunder should bear more of the burdens of constructing the just world order, not because of the relationship that they, as responsible moral agents, hold to the injustices of the past. Those advantaged by global racial empire should bear more burdens because of the relationship that their advantages hold to that history. And a good reparations argument should survive this distinction. Says Taiwo. Sorry, my son watches a lot of Taiwo, the little bus, which I think is a South Korean cartoon on YouTube. So it's causing me a problem right now. Anyway, so Taiwo goes on to argue convincingly that given the current state of our world, constructive reparations projects should center on the climate crisis and redistributing the risks and burdens of that crisis to those who have been disadvantaged who have been advantaged by the many processes that are contributing to environmental collapse. All right. Let's see, there we go. Okay, so ultimately, Taiwo thinks reparations projects should be measured by 3 standards. 1, they should make tangible differences in the material conditions of people's lives. 2, they should address the core moral wrongs of transatlantic slavery and colonialism to the extent possible. And 3, they should discriminate. They should distribute benefits and burdens based on the different relationships of persons and institutions to the core moral wrongs. Okay, so now that we have the sort of basic familiarity with Taiwo's argument for the constructive view of reparations, let's think about how we might apply this to the case for healthcare systems, the case of healthcare systems. So I propose that there are 2 conceptual approaches for how to go about this. I don't think they're necessarily in conflict with each other when it comes to practice in the real world, but I do think they are conceptually distinct and therefore worth discussing separately. And I'll mostly be focusing on the second one. So first, we could add a focus on just healthcare systems, along with Taiwo's recommended focus on climate change as part of reparations for the whole system of global racial empire. Or second, we could use Taiwo's framework to argue for a more enclosed reparations project that strives towards just healthcare systems as reparations for medical apartheid, which I will elaborate about later. So to go through the first option relatively quickly, we return to the 3 standards. the tangible material improvements, addressing the core moral wrongs of slavery and colonialism, and paying attention to the relationships of people and institutions to that core moral wrong. So how does Taiwo think attention to climate change will meet these standards? Well, he thinks that he argues that those who have accumulated disadvantage are more vulnerable to the risks and harms of climate change. We know this is true. There's lots of evidence of this. And he argues that in these coming years, as we go deeper and deeper into climate crisis, these impacts will come to really shape the lives of disadvantaged people around the globe. So definitely it would make a major difference to their material conditions to address their vulnerability to these climate change risks. Okay, so then next, he argues that the economic and political systems developed by global racial empire created the climate ecological crisis through forced migration and dispossession. So there's a strong relationship between the development of global racial empire and the current climate and ecological crisis. Then he argues, whoops, there we go. That those who profit from ecological exploitation and destruction should be liable for the harms experienced by those who are made vulnerable to that exploitation and destruction. Right. So those are the ways in which he connects climate change to his own standards for a good reparations project. So now the question is, can we do the same thing for healthcare and the standards? And so I think we can say that providing access to both healthcare and the positive social determinants of health would absolutely improve the material conditions of people's lives. And we'll look at a slide with social determinants of health laid out on it in a bit, but I think this is very clear. Okay, so then we can think, so how do we sort of connect this to the core moral wrongs of transatlantic slavery and colonialism? So I think Ruth Wilson Gilmore's definition of racism from the Golden Gulag, 2007, helps us here. So she says, racism specifically is the state-sanctioned and extra-legal production of exploitation of group differentiated vulnerability to premature death. Right, and so there are many ways to experience premature death, but we did see at the beginning in our snapshot that Black people experience a great deal of premature death relative to white people in the US. So I think we can see clearly with this definition how embodied health is really deeply connected to the core moral wrongs of slavery and colonialism. And then finally, we can think about the redistribution, where a redistribution where those who have reaped the accumulated advantages of access to both healthcare and the positive social determinants of health would be liable for setting up systems that distribute those benefits fairly, and where there would be particular liability with those who have profited off the accumulated disadvantage of those without that access. All right, so now I want to spend more time looking at this sort of second approach, where health and healthcare is understood as a specific site of moral wrongs and for a site for their reparation. So here I adjust the three standards to the realm of healthcare. So Taiwo's three standards in this case for healthcare reparations should make tangible differences in the physical and mental health conditions of people's lives and communities, should address the core moral wrongs of medical and scientific racism and medical apartheid to the extent possible, and then should distribute health benefits and risks based on the different relationships of persons and healthcare institutions or health damaging entities to the core moral wrongs. So let's return to some of the ways Taiwo recommended building out a reparations project. We want to avoid only looking at snapshots and track transfers of resources and opportunities. So here, environmental racism and its health effects are a really clear place to start. Obviously, we don't create pollution for fun. We create it for lifestyle convenience and for profit. So this makes the ability to pollute a benefit and exposure to pollution a risk or burden. And this graphic shows the unequal distribution of those benefits and burdens, right? So we can see that Latinx and Black Americans are exposed to a great deal more pollution than they produce, whereas white Americans are exposed to less pollution than they produced. So they are benefiting where there's there's a disproportionate risk for Latinx and Black Americans. This slide shows similar unequal distribution, but also notes a lack of access to remediation through the EPA for the very people most likely to suffer the harms. So at the bottom there, you can see people of color have seen 95% of their claims against polluters denied by the EPA. And then you can also see the greater risk of toxins, bad water, and bad air. Okay, so this is the same kind of question of distribution in some ways, with the part about the limits of the social and built environment, right? So we don't just want to, if you look at this standard, we don't just want to treat the disease, right, and the disproportionate disease burden that people of color bear. We actually want to change that disparate disease prevalence in certain communities that comes with disadvantaged and under-resourced social and built environments. Right, so we don't just want to give more healthcare to people whose health has already been put at greater risk. We actually want to, deal with those risks and reduce those risks. Okay, so here is that social determinants of health slide that I was promising. And what this graphic is showing is that racism, that's the gray line running through, is a mediating factor for all of these determinants. And what Taiwo is telling us is that we have to see the way that the advantages and disadvantages with respect to social determinants of health accumulate and reinforce. So among commonly understood social and economic factors that drive health outcomes, we find these factors like economic stability, neighborhood and physical environment, how much and what sort of food one eats, educational attainment, and community, social context. Histories and contemporary practices of racism and discrimination can and often do act through each of these factors. So employment discrimination, income and wealth disparities, and the frequent fluctuations of the employment sectors in which BIPOC people, Black people, Indigenous people, people of color, but in which these populations are often concentrated, all work against economic stability. Past and lingering practices such as redlining, urban renewal, suburbanization, and gentrification have resulted in enduring and intractable residential segregation across the US, creating neighborhoods that are separate and definitely not equal. Access to public transportation, parks, playgrounds, and essential goods and services varies widely based on the wealth of the neighborhood, its desirability to business, and the trust placed in it by lending institutions. Economics and neighborhood come together to ensure or deny food stability and to determine whether one can easily access fresh and healthy foods at affordable prices. Economics and neighborhood also come together in determining the quality of public education available to children, their preparation for higher education, and the affordability or even conceivability of pursuing a higher education. Racism and discrimination can also disrupt community and social contexts in a variety of ways, as is like in the form of negative relationships with law enforcement and the separation of families through mass incarceration or biased removal of children from parents by child welfare systems, just to name a few. So for example, Black men are 6 times as likely to be incarcerated as white men. And for Black men in their 30s, about 1 in every 12 is in prison or jail on any given day. Black women are 1.7 times more likely to be incarcerated than white women, and half of the incarcerated women with children are confined in locations more than 100 miles from their families. Meanwhile, an analysis of foster care placement rates between 2000 and 2011 found that 11.5% of African-American children were likely to enter the foster care system between ages 0 and 18, as compared to only 4.9% of white children. So 11.5 to 4.9 compared to 4.9%. So all of these things affect all of these social and economic factors that drive health. So looking at these social and economic determinants of health, some observers will be tempted to reduce the issues to ones of socioeconomic status or to search for so-called cultural explanations that amount to blaming communities of color for failing to instill in their members an appropriate work ethic or sense of personal responsibility. Such moves, however, pay insufficient attention to the long history of legal and political discrimination that deliberately stripped BIPOC communities of material resources and capacities for self-determination, setting them on deeply unequal footing with respect to the dominant racial and economic classes, and establishing social and political norms that would resist all efforts at repair and redress. So ultimately, we can see all of these things on this slide as means through which racism indirectly harms health. But we also have, direct effects. So it's pretty widely recognized that poor people have worse health for a variety of reasons. And most of us also probably know that Black and Hispanic populations in the US experience higher rates of poverty than the white populations. So this will obviously put Black people in a worse position in terms of health. But racism is bad for health in a more direct way as well. So I'm quoting a study by Colin et al. From Social Science and Medicine in 2018, but these aren't their graphs, they're just illustrative of their points. So Colin et al. Write, the association between socioeconomic status or standing and health has been shown to be positive, linear, and monotonic, such that with each additional increase in socioeconomic standing, we expect an individual's health to improve in a stepwise fashion. And that's what we see on this graph, right? More health, more wealth, right? Or more wealth, more health. They go together, stepwise fashion. But again, Cohen et al. Write, Black-white disparities in health are often more pronounced among high as opposed to low SES populations, and upward mobility does not seem to bring similar improvements in health for African Americans compared to whites. And you can see that here. Except this one is by education instead of SES, but they're not completely, they bear a lot of resemblance to each other. What you see here is that there's white infant mortality rates are generally going down for white women as they advance in terms of education. But they're fluctuating and actually often going up for Black women as they advance, so that by the time you're comparing white and Black PhDs or other professionals, there's this tremendous gap in infant mortality, right? So what many researchers are finding is that experiences of discrimination actually cause levels of chronic stress that worsen the health of Black people and other minorities in the US. For example, Mustillo et al. Demonstrate that perceived racial discrimination explains much more of the Black-white disparity in poor birth outcomes, low birth weight and preterm birth, as much more than maternal education, income, cigarette smoking, alcohol consumption, and depressive symptomology taken together, all of those combined. So, growing evidence points to these cases, to the effects of discrimination as a source of chronic and toxic stress for Black people in the US, which impact both their mental and physical health. Right, and so here we see the strong connection to Taiwo's emphasis on accumulation. Sources of stress that are being identified include perceived experiences of interpersonal discrimination, perceived threats of interpersonal discrimination. So it's even stressful to just wonder if you're going to experience discrimination. Major negative race-related events, which, like natural disasters, act as macro stressors. Broader cultural racism can also contribute to the negative health effects when members of stereotype groups, like Black people, begin to internalize societal racism and to self-stereotype. Improvements in SES do not protect Black people against the stress caused by discrimination. And in fact, middle-class Black people may be more likely to find themselves in predominantly white environments where their concerns about interpersonal discrimination are heightened. And then we also have growing bodies of evidence on the, scientific evidence on the bodily effects of intergenerational trauma. So, we're going through Taiwo's list of some of the things we want to do in thinking about reparations. So he says it also requires addressing patterns of care, concern, and attention. And I want to look at those patterns in healthcare contexts. So broader cultural racism also comes into play as it concerns the quality of health healthcare African Americans receive. As Williams and Mohammed, 2013, note, according to a 2003 report from the Institute of Medicine, Black people and other minorities receive fewer procedures and poorer quality medical care than white people across nearly all therapeutic inventions, from high technology procedures to basic diagnostics and treatment. And this disparity remains after statistical adjustment for variations in health insurance, SES, stage and severity of disease, co-occurring illness, and the type of healthcare facility. So they attribute this disparity to predominantly unconscious bias on the part of healthcare providers due to the prevalence in the US of cultural racism. That is the ideas of Black inferiority and white superiority that have historically been and remain embedded in multiple aspects of American culture. So indeed, as Lisa Ikemoto has argued, healthcare systems are often structured in ways that both reflect and enable implicit racial bias. She points, for instance, to the role of discretion, right, which connects back with this question of procedures, right? So within a complex healthcare system, a patient's experience depends largely on how those within the system decide to apply the multitude of rules and practices that are possible for the specific situation. So whether a test, referral, or therapy is necessary for a patient isn't a purely objective question. Medical professionals interpret which patients need what, and racial bias can affect that perception of need. She also discusses the high level of bureaucracy in most healthcare provision and the difficulty lay people have in navigating it, including processes like intake, appointment scheduling and resulting waiting times, referrals, lab testing, planning for follow-up care, and of course, insurance coverage or other patient assistance programs. So while healthcare workers may become experts at navigating these bureaucratic systems over time, most patients would struggle to do so. So it matters which patients are seen as deserving resources and help navigating the system. It also matters whether a patient receives care from a public facility where everyone may be overworked, or a private one where going the extra mile for patients is considered the norm. Ikemoto also highlights the emphasis on efficiency in healthcare. With limited time for interactions with patients, clinicians may feel the need to focus in only on what they consider medically essential. They may also resort to mental shortcuts, which can open the door to racial profiling. So evidence shows, as Ikemoto writes, evidence shows that the need to make quick judgments in time-pressured encounters in which cognitive load and task complexity are high increase a person's use of stereotypes. Compounding this concern about effective communication between patient and provider is the impact of the provider's institutional authority. The provider's expertise, the fact that the patient is relying on that expertise, and the fact that most encounters will take place in context and surroundings more familiar to the provider than the patient, is likely to make it harder for socially marginalized patients to communicate their needs and participate in deciding their own treatment. Meanwhile, structural and institutional racism often block access to even biased medical care in the first place. So Black people are more likely than whites to be uninsured, even after the Affordable Care Act. They're also significantly more likely to fall in the coverage gap, where one doesn't earn enough to get tax credits, but earns too much to qualify for Medicaid. Lack of insurance also typically prevents people from seeing the same physician over time, making it hard to receive preventative care, early interventions into diseases, or effective long-term management of chronic health issues. Okay, and then we come to Taiwo's warning against the binary division between the guilty and the innocent. I think the book Dying of Whiteness by Jonathan Metzl offers a compelling insight into why we need to look at system structures and not just these binaries. So while it's easy enough to understand maybe why well-off conservatives with good private insurance and access to positive social determinants of health would not want to change a system that's working well for them, it's harder to understand why poor conservatives without a good insurance or higher exposure and with higher exposure to negative social determinants of health would oppose changes to the healthcare system that would be to their own benefit and that of their communities. And so this is where awareness of the role of racial resentment comes in and provides a plausible explanation. So in Dying of Whiteness, How the Politics of Racial Resentment is Killing America's Heartland, Metzl summarizes the results of having conducted health-related focus groups with self-identified white and African-American men in Tennessee between 2012 and 2016. As exemplary of his findings, he offers the words of a 41-year-old uninsured Tennessee cab driver dying of liver damage caused by hepatitis C. And this is on the slide. "Ain't no way I would ever support Obamacare or sign up for it. I would rather die. We don't need any more government in our lives. And in any case, no way I want my tax dollars paying for Mexicans or welfare queens." Such an opinion, he goes on to show, was not an outlier in his focus groups. In fact, he reports many white men voiced a willingness to die, literally, rather than embrace a law that gave minority or immigrant persons more access to healthcare, even if it helped them as well. Metzl continues, "We often found that no ivory tower health policy explanation of the ACA's potential benefits came close to challenging concerns about the way that health insurance came from the administration of an African-American president or placed white Americans into networks with immigrant and minority populations." Indeed, one political science investigation found that President Obama's strong association with healthcare as an issue increased the polarization of public opinion on the issue, such that during his presidency, specifically for the years 2009 and 10, the racial divide in healthcare opinions grew 20% from President Clinton's plan back in 93-94. That is to say, healthcare reform has been a racialized issue and only become more racialized during and after Obama's presidency. So at this point, we've addressed the first standard here back on our standards for healthcare reparations. And we've also started to look at the third as well. And so we might see in the third an important goal of rebuilding a just healthcare system as the reduction of racial resentment to reduce barriers to the social solidarity necessary to sustain these very systems. It's worth saying something at this point about in the middle here on number 2, about the moral wrongs of the history of science and medicine. And I have a lot I could say about the moral wrongs of science with respect to attempts to provide scientific backing to invented racial hierarchies, which has served often retroactively to justify all sorts of practices of exploitation, expropriation, and other forms of colonial domination. But I'm going to skip that. If you want to ask about it in the Q&A, you're very welcome. Instead, I'm just going to do a quick review of some moral wrongs in medicine through the table of contents of Harriet Washington's groundbreaking work, Medical Apartheid. So if we just glance here at this table of contents, right, she's talking about this troubling tradition. She's talking about medical exploitation on the plantation, antebellum medical experiments with slaves and freedmen. You can think here about, our father of gynecology, J. Marion Sims. She talks about display of Black bodies in fairs and circuses, the Black bodies in the antebellum clinic, sending slaves to some of the earliest Southern hospitals for experimentation. She talks about anatomical dissection and display of dead bodies of Black people, grave robbing for medical schools. She talks about the Tuskegee syphilis study. She talks about eugenic control, forced sterilization, radiation experiments, research on Black prisoners, which is even, even more recent than some of these other things, and research that targeted young African Americans. So that in sort of a nutshell, right, are some of these historical wrongs that relate specifically to health and healthcare. And again, there are also those that relate specifically to science. Okay, but I want to wrap up here so we have time for questions. So by way of conclusion here, I want to just draw attention to an example. This is subsection 3 of the Breathe Act by the Movement for Black Lives, which is abbreviated M4BL. So you can look here, and they're talking about the history of systemic racism, ableism, medical violence, and neglect within the healthcare system, along with the denial of universal, affordable, competent, and quality care. And so it's placed medical care out of reach for Black people. And so they say these programs are a first and important step, along with equitable, high-quality, universal healthcare, toward ensuring health equality. So they've named that historical wrong, and they're talking with these programs about addressing it, right? So they want to ensure economic security for children, right, by establishing a universal child benefit, providing workers with paid medical and family leave, and prenatal leave to care for newborn children, or parental leave, sorry, to care for newborn children. They want to provide funding for pre-kindergarten and services on site with pre-kindergartens as well, universal school meals for all children, and baby boxes for expecting parents, right? So all these things are aimed at these social determinants of health and at early intervention in those as well. They talk about the child welfare system, which I mentioned when I talked about the sort of lack of community support, right? These sort of tearing apart of minority communities. They talk about reproductive justice, another really important topic that I could talk about for ages. And then they also talk about a health and family justice grant that would incentivize state and local governments to make health equity focused policy changes for a variety of underserved individuals. They list them here with concern about food apartheid, right? So again, these social determinants, healthcare access, community health workers, right? So and peer support specialists, right? So again, empowering communities about their own health. And the maintaining of the family bonds, again, going back to the child welfare system. And then these grant dollars would be used for things like nutrition access, healthcare access, or building the care economy. All right, so again, we can sort of return to these standards. And I think that BREATHE Act, and especially that subsection 3, shows real promise against these 3 criteria. Right, so as we look at how this and similar projects could be funded, right, then we could also pay attention to number 3 and look at sites of accumulated advantage or profit off of accumulated disadvantage and see those as places where redistribution of resources could begin. And that is it for me. And I look forward to our discussion. And here is the slide that reminds us how that discussion will be carried out.
So thank you so much. You have given us so much to think about and talk about. So let me just remind folks that if you have questions for Dr. Russell, please type them in using the Q&A function and we will address them. There were some questions that were submitted prior to the event as well. And so I want to acknowledge that we have received those and we will address those as well. And again, I want to remind you about and encourage you to fill out your evaluation after the event. And you'll see, it'll pop up in your web browser right after the event. You'll get a post-event email, and you can also find it linked to that presentation details document that's available in the chat. So Dr. Russell, it is up to you at this point. Whether you would like to leave your slides up.
I'll take them down. I can put them back up if I need to point to something.
Okay. So a few questions here. And let me start with some that came in prior to the talk as people are putting questions in the Q&A, although I see that we have some. One question is really about sort of the two-way street with health disparities, as it were. So one of the things you really stressed in your talk was the idea that the social and economic determinants affect health. And one questioner wants to know, is it a cycle? Does it work the other way as well? In terms of thinking about sort of those structures and how we best understand them.
So I'm sorry. So do
the health disparities then end up affecting the things that initially cause them? Does it become like
I do think that's right. Yeah, and I think this is the sense in which that we have this sort of self-reinforcement too, right? So if you become too sick to work, right, that's going to leave you in a bad neighborhood or maybe even take you out of a decent neighborhood into a bad one, right? So I think any of these, or again with the sort of concept of predatory loans and debt, like any of that stuff, if you're forced to do that for some medical reason or something like that, right, that can then go back into your living conditions. And I mean, certainly we could see the the premature death of a lot of African Americans as also contributing to a lack of community resources, right? So if you're, the more people that you're losing to death or incarceration, right, the harder it is for the community to support itself.
So I think those issues about cycles, right? How self-reinforcing the system becomes. Then, well, let me just ask you to comment on this. One of the things that I think is really striking about your account that is different from at least the way a lot of people interpret reparations, which may not be how we should be interpreting reparations, is that your account really talks about, as it were, not just we're making reparations for this static past event. That's how it is often, reparations are often maybe caricatured, but presented, discussed, questioned, like we are making reparations for slavery, as it were. You're saying that past set in motion this structure and cycle.
Yeah.
And so I wonder if you want to just say a little bit more about that contrast between pictures about reparation and how those issues about liability versus blame versus guilt versus innocence play in.
Yeah, I mean, and I have to emphasize this is Taiwo's account really that I wanted to bring to this question because I was very struck by it. I firmly and highly recommend the book, which I said came out this year. But yeah, so I mean, yeah, it's I think really, I mean, okay, I don't know if this actually convince. I mean, so they're going to be, there's some subset of people who's against reparations that is like never going to ever feel good about anything with that even implies reparations. But maybe there's some set of people that really is sort of not convinced by a sort of collective responsibility model. Right. So I think, but maybe sees themselves as interested in social inequality. And so I think Taiwo's emphasis on this accumulation and reinforcement of advantage and disadvantage, right, I think really speaks to, sort of a way to think about it that doesn't say, it's important whether your ancestors owned slaves, or it's important whether your ancestors, like were enslaved, right? So if you're a Black person who's family immigrated to the US after slavery, right? Do you have a right to reparations, right? So I think, these kinds of things really, people focus on these a lot, I think. And yeah, so I think what the accumulated advantage and disadvantage really speaks to, right, is it connects the present with the past in really concrete ways that can be really, really well traced and documented and have been, right? And so you can see how what happened then created the communities that people live in now and made those communities, lacking in the social determinants of health. But you can, and you can also see, I think, with his argument, how that's going to continue unless something changes, right? And so then I think this idea that, okay, we have to make these interventions that, and we should do them because they are related to the past, but also, because they are related to the future, right? So you have sort of both reasons there. And but it's important, and this is, I think, why Taiwo takes up reparations for this constructive project, right? He could have just written a book about what we should do about climate change and racial justice, right? But he wrote a book called Reconsidering Reparations. And I think what he really wanted to get at here, and I think what we don't want to lose, which will continue to make some subset of people really angry, is this idea that there's something important in the acknowledgement of what happened and the effects that it continues to have, right? Reparations aren't just material changes or material payments, right? They are like acknowledgements of responsibility that feel genuine, right? Because it's very easy in all cases, in all places, to say something. It's harder to do something, right? It's harder to actually put resources to something. So I do think that there's something about connecting it to the past that it's symbolically important, but for Taiwo, it can't be separated from material changes, right? You can't have reparations that are just, we acknowledge responsibility, doesn't everyone feel better now? Right. So, this is why I think he sort of says, I'm going to take this idea and then talk about building a just world, but I'm going to keep that reparations element in it because it matters.
And then if I could just invite you to briefly comment on the difference, which I know you touched on this in your talk, and you also talk at it in some length in your paper in the American Journal of Bioethics. On the difference between taking responsibility and our viewing certain groups as guilty, right? As the difference between guilt and responsibility. You talked here about liability, I think and
so that definitely isn't in the paper that I wrote. This comes from Taiwo, and I wrote the paper before I read the book. So but yeah, I mean, so I think it's an interesting idea, and it works, I think, for him particularly well for sort of the idea of climate change. Although, I mean, the connection with environmental injustice and health it also works really well there. But yeah, it's this idea that if you're out there kind of doing things that create risks, and then bad things occur, it's not really important whether you're responsible for the fact that the bad thing occurred. It's the fact that you are out there doing the thing that has the risk, right? So, if you're, so I mean, if we take another environmental example, right, like oil spills, right? So it's not the fact, it doesn't have to be, it shouldn't, he thinks, and I agree that you shouldn't have to prove that it was negligence that caused an oil spill to make the company responsible for it. The fact that the company is out there profiting by moving oil through the water, or extracting oil in the ocean, that fact, their profit is based on that risk. There's always that risk of the spill, right? So it doesn't really matter whether they did something wrong that caused the spill. The point is they have to assume the risk, that risk has to be theirs and not, the oceans or everybody who, lives or, makes money off of like fishing or whatever they do in the ocean, right? It's not, those people aren't the ones who are profiting from, the work, right? So in some ways it's about, just redistributing risk and burden and then benefit, right? So that, so if we think about disease burden and disease risk, right, and the way that the social, the social determinants affect that, then we think about, okay, well, we need to redistribute people's access to, good air and parks and jobs and resources and things, right? Because it's not, there's nothing fair about it, right? And no matter whether you were directly responsible or not, right, you're living your life here in this nice area without toxic waste, but you are creating in your life waste, right? You're using plastics, for example, but you're not having them dumped, or produced in your neighborhood, right? And that's not, poisoning your water supply or something like that, right? So it's just that sort of idea that, if you're free from all of these risks, it's because those risks are concentrated somewhere else. And so it doesn't have to be that you created the risks. So there's two different things. There's the people who do create the risk, and then there's the people who don't have to deal with the risk, right? And so that's the sort of redistribution that I think Taiwo was really getting at, is these risks and these benefits, right? So and for some people it will be the sort of lifestyle and convenience benefits, right? Just sort of how we live in the world and all the things that we have and use, and our phones, and all the, I heard the other day there's like 5 phones for every person on the planet, or 2 phones for every person on the planet, or something like that. Anyway, and that is creating a lot of electronic waste. But yeah, so it's that fact of being able to profit from a certain sort of system, or either directly as like sort of financial profit, or just as living in good environments, and the fact that that is only possible because some environments are not good, right?
So a sort of related question is this. It's a colleague who says it's a question that they've been grappling with. What do we gain by casting health equity efforts in the framework of reparations, she asks. Is the force of the reparations framing really in the motivation for taking equity with full seriousness and commitment, or is it also about the distinctive approach to equity, that is to say strict liability, that Taiwo offers, but is maybe less shared in those broader discussions about reparations that we were talking about at the beginning of this discussion period?
Yeah, I mean, so I think it goes back to what I was sort of saying before about the sort of expressive effect as well, right? And so this is why I think the movement for Black Lives legislation, the Breathe Act, is really interesting, right? They're calling for things that are largely universal, right? I mean, the thing, you know, the sort of the baby boxes, the lunches, the, you know, and this is, I mean, this is incredibly important because status concerns are also a huge source of stress, right? So, you know, and there's terrible things going on in places with school lunches. It's, you know, like you hear about it and you just want to cry. So it's important that it be offered to everybody so that some people don't stand out as the sort of people who are getting the free lunch. But you can see that, you know, that this movement for Black Lives, right, has framed it in this way for a specific reason. And I think that has to do with this expressive effect and linking it to actual material goods, right? So there is both the acknowledgement of the harm and the fact that you know, some people are living well at the expense of other people, even if they're not directly sort of, you know, choosing to harm other people, right? And that has to be recognized. And if that doesn't get recognized and that doesn't get connected historically, then a moral wrong kind of goes unanswered, right? It does, like, we ignore the past, and that sort of also threatens to make it sort of seem like the whole sort of past structure was just kind of an accident. Like, whoops, things got distributed this way and it's been building up and advantage has been accumulating, and that's kind of a bummer, we should fix that, right? But no, actually, I mean, you know, there were real wrongs committed deliberately for profit, for the establishment of this country. So yeah, so I think that for me, that's, you know, that's sort of why what I think Taiwo does, that I think is a why of thinking about in terms of reparations, is to really acknowledge there's a past of moral wrongs, and they should be addressed, and addressing those moral wrongs, connecting them, is important, in also while also providing things that are you know, that are just sort of good policy practice in terms of reducing disparities. But like I said, this is what the movement for Black Lives did, and I think this is why I think Taiwo's book explains a lot about why the legislation is summarized in that way, with that that first heading about the past.
So there are a couple of questions about resistance or resentment that I think that it would be good to sort of have some discussion around. One questioner is concerned about what implementation looks like, or how we move toward implementation, and inviting the public, and specifically white people, to think seriously about reparations, given you know, what it's sort of the resistance that has occurred toward them. And another questioner specifically sort of focuses in on those issues about racial resentment that you raised in your talk. And so sort of like, how do we move through that? Do you have words of wisdom for us about that? I mean, I know the argument here is really an argument about here's why we should.
Yeah, no, I mean, and you know, and I mean, I brought up you know, I brought up the Metzel book, you know, not paying attention to the role of racial resentment in healthcare policy in the US. You can't understand why like things are happening the way they are without that understanding. And I mean, and also, and I think I mentioned this in the article, in the AJOB article, but you, like, it mirrors, sort of the movement out of, at the end of slavery and Reconstruction, like the resentment, like how do you convince poor Southern whites who don't really benefit from slavery because it really just drives down their wages, to go and die for your Civil War, right? So you need, you have to sort of stoke this resentment and also, sort of convince them that simply by being white, they experience superiority and that they have to protect that somehow, right? So I think we see sort of, we see a mirror of what was going on during the Civil War and during Reconstruction in this sort of racial resentment that that Metzl identifies. So, I mean, so part of it is, I just feel like we have to see these patterns before we're going to be able to address them. But I don't really know how we fully address them. One thing that's interesting in Taiwo's book as well, in his introduction, he says, we've been writing these books about kind of what's wrong and trying to convince people who don't agree with us, or imagine people who don't agree with us who are somehow going to read our academic books, which is not that likely, that there's something wrong. We've been sort of spending all this time trying to sort of show people there's a problem, like, as if they sort of just don't know, and we just have to tell them, and then they're going to fix it. And he says, I'm not trying to do that with this book. I want to think about a way forward, and I'm going to do it without focusing entirely on all the people that might disagree with me or what it would take to convince them, if they can even be convinced. I'm just going to think about like what needs to be done, and I'm going to sort of imagine what we could do and how. So I think I think that's important. So I think, but what he then does when he talks about some of the climate change reparations things, and what I'm doing with mentioning the Breathe Act, although that is a sort of larger legislative attempt, but it also, so some part of it can be about, well, what can we do in local places to enact these sorts of changes, right? So it may not be the case that we can get the whole country on board toward a legislative solution, like we can get sort of the right people in the right places through popular votes or electoral colleges in order to to bring about a sort of large scale change. But we might try a number of different projects, right, that have, that take those sort of three requirements seriously, right, that we're going to really change, we're going to really focus on material things, we're going to connect it to these core wrongs, and we're going to try to place the burden for making these changes on people who have benefited, right? So and another thing that Taiwo uses as an example is Georgetown and some of the university and some of the discussions that they've been having over the slaves that were sold at a time when Georgetown needed money, and the descendants of the, and so on and so forth. And he's at Georgetown, which is why he sort of specifically connects him with that. So I think, so there could be sort of smaller scale projects where people try to convince particular institutions that have benefited in particular ways to support programs that try to do this kind of work in a sort of framework of reparation and building a better system, right? So maybe we don't convince everyone necessary for electoral change and legislative change, but maybe we, we at a smaller level, we say, hey, Johns Hopkins, lots of Black bodies were found in your skeletons were found in your basement back in the day. And, what if you did something like this in order to deal with that, right? So that, I think that's kind of what Taiwo was kind of urging too, is like, let's see how we can use this framework to do action at whatever scale we can do without having to necessarily, convince the people who don't want to be convinced.
Thanks.
And then, maybe if we do structure a more just world and people, or parts of a just world, maybe people will think, hey, I want to be there, not in this place that I am, and stewing in my own for it.
That it's a path, yes.
Yeah.
You don't have to do it all at once, right? So there's a question here about the closure of the med schools at historically black colleges and universities, and whether sort of reopening them might also play a role in reparations. I'm wondering if that's something that you've thought about. It's not related specifically to the Movement for Black Lives proposals that you raised, but
No, and I mean, and that's just one example. And I think that is, I'm actually looking at the question as well, and I think that is a really good thought. You know, because I do think that that's and because, you know, okay, going back to way back to when Taiwo was talking about accumulated advantage and disadvantage. He said that also applies to things like citizenship and violence and knowledge, right? So if you think about like sort of knowledge, medical knowledge, knowledge of how to, you know, care for people, community knowledge of how to care for each other, right? These things can actually be sort of stripped away. They can, you know, I mean, you know, you think about the process of, you know, kidnapping people from Africa and bringing them to the Americas, up and down the Americas, you know, and processes of separating people, trying not to let people be too much with their own sort of ethnic groups, too much able to speak their previous languages, right? So there's, you know, this sort of stripping away of knowledge, right, is part of these sort of core wrongs. And so I think the sort of underskilling and stripping away of the possibility for, you know, for more Black doctors, and more, you know, sort of local healthcare and things like that, definitely sort of fits in terms of these moral wrongs, and provides, I think, you know, in that case, a specific site of really thinking about, and that's part of, you know, what Taiwo really wants to do, right? He's like, it's not just about sort of good feeling for all in a sort of global sense that everyone in the world should have human rights. It's also this connection to these actual institutions and wrongs, right? So I think that's a really good example with the medical schools of like, let's connect this to this particular wrong and think about, okay, what can we do to go forward, right? To be not be backward looking, but be forward looking, informed by this history and the consequences of this history and the way that advantage and disadvantage were accumulated through those closures.
So a number of questioners really want to know what we all can and should do. And there are questions at the level of sort of healthcare systems and questions at the level of the individual healthcare professionals. And I'm wondering if you can speak to that.
Oh gosh, you know, philosophers love to, you know, identify problems. It could be better, you know, and I'm certainly one of them. Yeah, I mean, yeah, and I guess this is sort of the argument of my A-job paper, right? Was about kind of like, well, where are you situated in healthcare in general, right? And then kind of what can you do from there, right? So I mean, so I think, I mean, I do think, I strongly believe that this is a really good place to start when you think about sort of any kind of change. You know, what might I know about the history of my institution? You know, what might I see about opportunities that, you know, maybe, you know, some institutions are looking for ways to do things, you know, and I don't know if their motives are always, you know, perfectly altruistic, but nevertheless, some institutions are looking for ways to put in resources towards these issues. So, you know, that's sort of something to look at. But yeah, I mean, it's such a hard question.
And you know, part of the force of what you were just saying is we don't all have to be overwhelmed to think that we need to make changes on a global level, but that action sort of where you are and where you work can change things kind of incrementally. You know, it's a process, as you were saying before. It's not like, you know, we wave a magic wand, as it were, and it's all taken care of globally.
Yeah. And I think, I mean, I see someone mentioned also sort of scarcity scarcity too, and the sort of scarcity mentality in
Yes.
the absence of actual scarcity sometimes. But I mean, I think there's a lot of good. There's a couple different pieces of evidence I think are interesting. One is, sort of the idea that, the U.S. has like pretty bad healthcare, most people feel, yet it spends an inordinate amount of money on it, right? So we have evidence that the money isn't being spent in the way that, that we should have much better healthcare for how much money we're spending on it, right? And that I think, can be connected to a lot of these social determinants of health, and also the role of, for-profit insurance companies, et cetera, et cetera. But I mean, so I think that's one way to sort of try to talk to people about the sort of scarcity, like we're actually spending a lot and getting very little. Let's do something different. Then the other thing it's interesting is about economics. The huge wealth divide that we have, and the sort of 1%, 99% kind of deal, it's actually really bad for economies, according to economists, right? And really bad for societies. People are less happy in very unequal societies, including people who have a lot. Right, because there's a lot of there's a lot of status anxiety and sort of so if we could make the society a little more equal, right, it would actually be beneficial mentally for mental health of lots of people. It'd be beneficial for the economy. It'd be actually broadly beneficial, right? So there's, I think, some interesting arguments that sort of say, like, look, actually sort of making these changes makes everyone actually better, right? We all feel better when we're not constantly worried about whether we're going to be sort of closer to the 1% or closer to the bottom 20%, right? So, and there's some ways to kind of think about some of the money stuff and the sort of scarcity stuff, that this may not actually be a zero-sum game, but we might actually be able to improve a lot of outcomes by restructuring what we're doing.
Yeah, but that idea about it not being a zero-sum game is just what I was thinking while you were describing that. There is this sort of attitude about redistribution that someone who has things necessarily loses, and essentially what you're saying is that that's not necessarily true. I think we could talk about this probably for another, oh boy, the rest of the day, but we're out of time. I really want to thank you. It's been a really excellent conversation, very, very thought-provoking, and I really appreciate your time and your expertise in joining us here today. And I want to just take a moment to remind people about the programming that we have coming up next month. So there's an Unpacking Bedside Bioethics by Joan Henriksen on what to do when patients can't make decisions for themselves. And next month's Ethics Grand Rounds will be Professor Mary Faith Marshall and Lynn Paltrow talking about the consequences of overturning Roe versus Wade. So we hope that you'll be able to join us for those events next month. And once again, Dr. Russell, thank you so much for being here with us today.
Thank you, and thanks for the questions as well.
Goodbye, everybody.